Okay, I'll just start. I thought there was gonna be an introduction, but I'm Doris Hansen. I'm a PA. I graduated in the States. I attended a 5-year master's program, composed of like 2 years undergrad, 3 years master PA school, and that was directly after high school. So I got out of school pretty young, and I've been a PA now for close to 12 years. Um, Prior to this, I was working, my first job was in pediatric neurology. And then I did primary care in rural areas. And then I did reconstructive plastic surgery and hand surgery. And for the past 3 years, I did cosmetic plastic surgery. So for today, I don't know if you'll be able to suture like a plastic surgical PA, given different type of settings and time frame and what's more practical for your practice. But I can maybe instill some techniques or things that I've learned along the way, and you can see how you find that relevant to your like common practice. And then also, I just have a few slides, and then we're going to get into actually suturing. We have pig's feet today. I don't know if I have enough materials, but I think we're gonna have to share and yeah, and kind of go from there. So feel free to ask questions along the way. You can stop me. And this is not being recorded, so everything in this room can stay in this room. All right, here we go. Okay, so this is some of the topics we'll be covering, not in this particular order, but we're going to it's going to be a lot of overlap and integration of suturing techniques, local anesthetics, what type of suture to use and where to use it, which tissue to use it on. And I'm really going to focus on areas of tension because tension on the skin tissue really, that's what not prevents the scar, but reduces the appearance of scar, like the better likelihood the scar is outcome. Okay, so first we start with local anesthetic. Most of the time I'm in the operating room, but this applies for like bedside procedures, outpatient procedures. You really want to make sure, even patients that come back in for small like revisions and things like that, you want to make sure that the patient is comfortable first before you start suturing them, because if they're not comfortable and you just start and they're in a lot of pain, you're not going to be able to efficiently work on them, and it may disrupt your time and the outcome of the trauma or the incision. So we just talk about the common choice of anesthetic. So usually I use lidocaine with epinephrine. It usually lasts 1 to 2 hours, and then if you add bupivacaine or marcaine to the mix, it can extend the duration from 7 to 8 hours. So this is like good for pain control of superficial lacerations. And then just a little bit more about lidocaine, which is on back order in most of Canada, and I think parts of the States too. So it's an amide molecular structure. It's metabolized in the liver. Rarely patients have allergies to this, but you should always check for allergies regardless. When you add epinephrine, the epinephrine is a vasoconstrictor. And the epinephrine also prolongs the local anesthetic usage. And it takes about 5 minutes for the epinephrine to kick in. But the effects of the lidocaine are usually immediate. So once you inject, you can pretty much start, but the vasoconstricting effects take about up to 5 minutes. This is just the typical dilution. So it's like 1 part epinephrine to 100th part, 100,000 part of the solution. So if you have to like mix adrenaline and lidocaine on the side, then it's like a fraction of what the total volume is. So just keep that in mind if you have to do that, since the back order is no time limit on that back order. Okay, so I'm just talking about sutures. Dissolvable or non-dissolvable, where do we use them and when do we use them? So first, dissolvable sutures, also called absorbable sutures. They're a synthetic polymer. They consist of polyglycolic acid, polylactic acid, and they're natural materials that create, the idea is that they create an inflammatory process and then the body will break it down. These are some other natural materials that are used for absorbable sutures, but we'll talk about some of these in the next couple of slides. Then you have the category of non-dissolvable sutures, non-absorbable, and these are artificial fibers made of polypropylene, polyester, and nylon. And they also contain like a coating to enhance their performance characteristics, which means that the coating can actually help with gliding through the tissue. That's it. So some things with the absorbable sutures to recognize is that you would use this if you're doing anything within the body cavity. So if you're burying a suture or you're pulling tissue together on a deeper level, then you definitely should use absorbable sutures. I mean, I don't think we ever really use permanent sutures. The most permanent thing that we do use is like a PDS, which lasts about 90 days to sometimes 6 months. But most of the time it's absorbable sutures. And these are commonly called vicryl sutures. That's just one of them. And they can create hyperreactivity. So because they're absorbable, they create the inflammation process. And some patients may have an over hyperinflammatory response. So we don't typically use this that close to the surface or on the surface at all. So at least with the vicryls, we don't. We'll go into like the monocryls and other things that we use on the skin. And then skin, when there is a high tension, it's better to use non-absorbable sutures to begin with. And then on the skin, you can use things that are stronger, like proline or nylon. Another thing that you take into consideration when trying to figure out whether or not to use absorbable versus non-absorbable is if you can actually remove the sutures and where the patient lives, if they have access to someone that can remove it. This is just the type of absorbable suture, a chromic gut. People commonly, it's a very fragile suture in my opinion. I would use this as like a touch-up for something that I've already kind of sutured preliminarily. And it comes in a package of like isopropanol, yeah, alcohol. And then we'll talk about what the size of the suture and where to use a suture. So I think this is important just to build like also confidence in recognizing like what you're going to use and being confident, being able to tell like which type of suture, what size you need and where, especially like if you're already in a sterile setting and you need the nurse to grab you a suture or you need something for the field. So this is something that I actually learned on the job. I didn't even learn in PA school, is actually identifying like the suture, the length of the suture, the type of needle it's on, and what this means, like monofilament versus braided, and how that comes into play in scar and healing. So the size is right here, 4.0 monocryl. And as you go up in numbers, obviously you guys probably already know this, that the suture itself is thinner. So like a 6.0 would be thinner, and then a number 1 vicryl, for instance, would be a thicker thread. And then this is the length of it. So this is 18 inches and this comes in different lengths. It's on a P3, which is a very tiny needle. And then this is like the kind of the cross section of what the needle looks like. So that's something to keep in mind depending on where the tissue is, because sometimes this can easily break the tissue, especially if you have like fragile tissue or like cancerous tissue. And this is a undyed, this comes in dyed. This is like clear, usually clear. And monofilament is just the type of how the suture is. So it's non-braided. And then this one is on a 0, which is the size of the suture, and the vicryl on a CT1. And again, you can see the cross section here of the needle itself, what it looks like. And then this is the length. This is a typical length for vicryl. And this one, if you can see, it's undyed and braided. And braided is just how the suture is put together. But typically for things that have more texture in them, there can be a potential pocket for bacteria. This is a common one for skin closures. This is a non-absorbable suture and commonly known as a nylon. Usually we say fluoro-nylon. We don't really say ethylon. And this is on a PS2, reverse cutting. So these are just some things to keep in mind when you're requesting it, or maybe to notice when you're in the operating room, if you have to request something. And this is good for, this is not absorbable, so you want to only keep this on the surface. Okay. So usually in order to reduce tension, if it's like a wider gap of a closure, then you want to get the deeper layers first and then work towards the skin and reduce the tension on the skin. And the dermis of the part of the skin has a lot of strength. So once you bring like the fascial layers together and the subcutaneous layers together, doing like a deep dermal buried knot is like the way to perform this, is because you want the knot to be buried on the bottom side so that it dissolves down there versus like up top here, and then it can spit out to the skin surface. And a lot of patients will come back or complain about like pus or infection and things like that. But meanwhile, it's just like your knot from your suture. So for this instance, usually you start from deep to superficial, and then you come back around into like a circular loop and do superficial to deep, and then tie the knot on the bottom. And this is a great way to reduce tension again. Okay, so this is just your regular simple interrupted suture, and this is really for superficial wounds. But the nice thing about this, if you don't really have time and you don't think it's a very deep wound or trauma, then you can take a really big bite and kind of loop in the dermis and the subcutaneous tissue and then tie the knot on the outside here. So this like kind of, you can take a deeper bite and kind of swing it around and then tie your regular knot. And then this is a subcuticular style. So this is like when the suture is kind of hidden. And this is like the plastics go-to when it comes to like aesthetic and cosmetic closings, just because it looks pretty and the patients are like, oh, I don't even see a suture. There's not even a stitch. But that's because we like hide it. And then we start with a buried suture, and then we use the upper part of the dermis into the epidermis and kind of like loop it around like this. And I'll go over like techniques on how to make this look nice. And the nice thing about skin is that you can like kind of scrunch it a little bit, so that, because it always will stretch out. So always remember to pull it taut when you're done pulling through the suture. Typically I use an absorbable suture for this, but it can be done with a Prolene. We just have to advise the nurse or whoever's taking it out that you used a non-absorbable suture, because sometimes you can cut the knot off and then the rest of it will still be buried, and then you have to go fishing for your suture. This is a horizontal vertical mattress. This one is nice because it's good for like high tension areas. So sometimes it's used on the hand or the legs when there's not a lot of skin to not a lot of loose skin to bring the edges together. This is a great suture because it inverts the skin edges and it can like hold a lot of tension because it breaks down the tension across the surface of the skin. And then you're ready to prep now. So you picked your suture, you've done your local, now you're ready to prep. And typically you can use chlorhexidine, and that's probably the most effective for antibacterial and bacteriostatic solution. The only thing about chlorhexidine is you can't use it on like oral cavity surfaces or any mucosal gland. So if you're doing something around the eyes, you want to use betadine instead or iodine instead. This can be caustic to like some of that tissue if you're using it in those areas. Any questions? Is there any issue with the chlorhexidine, or are you talking about just alcohol? Yeah, so it depends if you're washing it out with like chlorhexidine, you shouldn't really be washing the wound out with chlorhexidine. This is just like to prep the surface. This is more if it's like a clean surface and you haven't made your incision yet type of thing. If you're doing like a cyst removal, for instance, or like a mole excision. If it's already like a trauma, then you can try to clean with like iodine around, and then you can also just like do a flush, like constant flush on the actual tissue, exposed tissue. But yeah, you shouldn't really use it into like open area just because it can be like caustic on the tissue and it would delay some wound healing. At least that's what they say, but I haven't really seen that. That's what they say in studies and things like that. Yeah.
Is there any difference in like cosmetic outcomes in the topicals?
Yeah, so not really. It depends on when you take it out. Because if you have a non-absorbable suture, you can still have good outcome, but sometimes it can leave imprints on the outside of the skin if you're doing like a simple interrupted, for instance. If you're doing like a subcuticular, usually not the case. But there's not a real difference. It just depends on how long you keep the suture in for, because then you can have scars around where the suture is on the skin. Okay, so usually this is just like a general rule of thumb for suture removal type of thing, or and even staples. So usually if it's on anywhere on the body, then it's like 10 to 14 days, and then the face is like 5 to 7 days. You can also, some people do use like for superficial traumas and wound closure, some people will use like a dermabond or glue to keep the skin okay. But again, I don't know how cost effective that is depending on where you are. It may be easier to put a suture in, but I don't know. It just depends. And also depends on like the patient too. If you have like a pediatric patient who's moving around constantly, like maybe saving them the injection of holding them down and trying to inject local and then trying to do sutures, you may want to opt for something like glue, given it's like patient-based scenario. So, but staples and glue have also good outcomes when it comes to scars and like wound healing too. Staples, especially, we even use it in cosmetic plastics for high tension areas like the lower back. If we're doing like a back lift after weight loss or a bra line roll surgery, so we tend to use staples too, but they have to come back in to remove those. And then as far as like dressing, like people think, oh, the dressing is like something that helps with outcome. Not necessarily. It just, even when it comes to infection and things like that, I think it's just the patient's the way they had the trauma, and like it has to do with like their own comorbidities. So the dressing is just whatever you can use. That's, I'm into the minimalist dressing. It's cost effective. You keep it covered for 24 to 48 hours, and then they can wash it with soap and water and then pat it dry with a clean towel. And then a non-scented moisturizer. You don't want to put too much polysporin or any type of antibiotic ointment, because it can make it more inflamed over the next couple of weeks and things like that. So some people will like just constantly put polysporin and it'll be red and erythematous, and they think they have an infection, and it's like they have to stop with the antibiotic topical. So I just say it's non-scented moisturizer, less is better. Okay, so we're gonna just go over some of the videos. These are some of the typical cases that we do on a regular basis, including like a tummy tuck abdominoplasty, a breast mastopexy. So you'll see me in the next few slides, just a video of that. I want you to keep in mind, like just noticing the technique of like holding the needle driver, bringing gliding the needle through the skin, and then picking it with my forceps, and then using my forceps to like evert the skin to guide my needle into the next opening.
That's the one with the fake lamb, right?
So this is on a deep dermal level. So actually this is the fascia. So we'll do a fascial layer closure, and then I'll go back on the dermal end. This is just like a running 3/0 Vicryl that I'm using. And then I just tie it at the end, but then I'm going to run it back.
Fake crab.
So I just put a knot just to secure it, and always like anytime you're doing anything, even on a smaller scale, you want to make sure you remember to keep tugging on that suture. It's just so that there's not enough space for it to spread open, because the skin is pretty pliable, and you want to hold on. This is now the 4.0 monocryl that I'm using as a subcuticular running. And again, I just use my forceps to help like evert the skin and guide my needle to the next point of exit. So I'll use my needle driver. I prefer like a smaller needle driver. It just gives you better control. So even if you're using, I'll use a larger needle driver for like a CT1 suture or a number 1 vicryl or things like that. But I'll use a smaller one for like the 4.0 monocryl. So this is just a 4.0 monocryl. I know it looks so cute and dainty. The military. They're like, oh, that's pretty. That's pretty. So yeah, this is just showing you again. I'm just using just pushing it forward, and it's not a lot of force, but if you're in the right plane and your angle of insert to the skin is right, then you're not going to struggle to like push it forward. We're going to struggle a lot with pig's feet and our forceps today, but in a real setting where you have adequate or semi-adequate tools and real skin, it's the gliding of the suture, it won't be as bad. Like you just, if you're not getting it through, then you're not holding it right, or you're not you didn't put in the needle driver in the proper setting. So okay, so this is I'm starting in a running subcuticular and areola, and I just start with a deep buried monocryl suture. So I throw my surgeon's knot in, and then I'll tighten it there. I usually do 4 throws most of the time. Pretty much all the time, at least 4. Unless I'm tying in a drain. So I just cut the one tail end of the knot, and then now I'm burying it underneath the knot, and then I'm pulling it through to the superficial like epidermis dermis interval. And then I'll run this all the way around. And I'm also using a 4.0 monocryl. This is undyed, so you can't really see it too well. Again, I use my forceps to kind of pick the top of my needle when it's coming out, because if you use your needle driver to clasp the top of it, it can dull the tip of the needle. So, and then I'll show you here, this is like kind of what it looks like on the other end. Like I've come already halfway around, and this is all monocryls on the surface, but they're in deeper side is like vicryls. So when you're having a hard time, there's tissue popping out and it's a tight closure, I just take smaller bites. I push the tissue in as I'm pulling the other suture through, and I'm like taking smaller bites as I go along, because you just have to work that tissue back in. And again, like I'm using my forceps to invert the skin, and actually guides, like wherever I insert my forceps, my needle is going to come out onto where my forceps is exiting. And usually on the field, we'll just like, I'm working with like 2 other people in the operating room, so we have to maneuver in a way where it's like, you just have to like do anything. Like you have to go backwards, you have to go forwards. Like it's just, you have to maneuver in that way, work with everyone. Yeah. Yeah. I usually like pickups with teeth because you can be pretty aggressive on the skin with it, and it's not abrasive to the skin, and I don't know, it just doesn't leave those clamping marks. I feel like I have better control. It could be your own preference, but that's what I like to use. There's finer forceps, and then there's like heavier ones for like the deeper tissue. But all right, and I think that's pretty much it. We can watch this again, but the best thing right now is to actually practice. So we have pig's feet that were donated to us for today, and we can get started. And I'm going to come around to each table, and then I can show you guys how to get started. I think we should start. The pig's feet are not pre-cut. We do not have blades, so you're going to have to use the scissors to make your own incision. and make it a wide incision so you can do some deep buried sutures and then do like a running on top. You can, I didn't talk about baseball stitch, which is a running continuous on the outside. It's like basically like an not interrupted, but it's like just like a running on the surface. That's good for something quick, something under like a little bit of tension. But you can practice that if you want. I'm gonna come around. Oh yeah, sorry, yeah.
I've only ever like practiced running this is not big speed. I always have a problem lining things up. They always puckers at the end. I don't want to. What do you do to avoid?
What do you mean it puckers at the end?
Like there's always like kind of a bump or a pucker. Or the tissue doesn't line up at the end.
Yeah, so there's a way to like, it depends on what the incision looks like. There's a way to like work in the corner. So what I would do is before you even get to that corner, try to see if it's like this, then you have to like bring it in, like use your forceps to kind of get an idea of how you're going to work this in. So you may need to take longer bites on the top surface, for instance, and then bring it forward. So you have to like pull the, I don't know, it's like hard to interpret, but there's a way to work it in where you bring the longer surface in towards the shorter surface. Yeah, and then you can like work it in, like, and scrunch it in where the outer corners won't be on the looser side. Yeah, you would take it on the looser side. Yeah, but you have to keep that in mind before, like, as you're starting. Like, you can't do it when you get towards the end because it's going to be too late. You have to take, I'm not talking about, yes, longer bites, but not like a big difference, because then you'll have like folds along the incision. So you want to just keep reassessing, like with your forceps, like bring it in a little bit and see how it looks, and then try to work their way in that way.
I'm afraid to do it on person because I've always messed it up on Facebook.
Yeah.
So, yeah.
Oh, I can come over and then we can work on it. Okay, so a lot of things you guys are gonna have to, I didn't set up the other tables in the back just because I didn't know this many people will be here. So there's gloves here, and the white suture kits don't have that much in it, but keep the plastic wrap because the pig's feet are pretty, yeah, you need like a plastic cover for the pig's feet. And then when you're putting your gloves on, try to do it like in everything in like a sterile manner where you're like putting your gloves on. Oh, also some of the pig's feet we used yesterday, so they may have sutures in them, so just cut them out.
That's what my first time. I mean, my own run for you. That's happened. Some of them, if you're not going to all medium or large. Like, I always say, Now, actually, that's actually what I kind of
Does everybody have a needle driver forceps on their table? And then does everybody have, like, you can share the scissors. It's self-serve with the pig's feet, so help yourself. And then sutures. Any table needs sutures. The 5-0 Vicros are very flimsy.
Actually, that's very good. So, John, where's the moment? No, I introduced. So when never seen it's like somebody belongs for it was about 30 or 40 students. I got it in home game and
Yeah, you're just talking up and under, and then. I should put the A. That's my favorite part. Yeah.
Yeah, okay, so mine, I oh, I've been, so basically, you just input your result. Like it's not. Oh, here.
The last part of this thing is gonna be my age or not, you just get slop it over, so like I'm getting it back.
Grab your tail.
I love the thing. Very, very. Okay.
feel like I'm
I like that.
And then,
So, yeah.
So that's where it's.
and it's like, I'm really.
It is the right place. You gotta find it. You're getting a layer of people that are deep and a layer of people that are down there. So you get a deep bite and then that's probably. Wondering. Well, yeah, it's.
Yeah, I mean,
Yeah. So I just, these are not the ones who they're very complicated, but policies, over the amazing, yeah.
And then go back down to the
That's what I started it right. I'm going to read So mine's technically. Mine's technically. But they weren't. 2 days later. Because I graduated, my graduation course, and they were like, yeah, and so. If you don't. So so you guys are not. So unfortunately, it's not. But so I ended up this. Everybody else. So it was me, you, and the yeah, lives more. Yeah. Yeah, freaking meeting up and speak. I was just thinking, it's back on. Yeah, I was there. And I explained this all. We've never been, we got to the day, we got to do over the wall one. And I'm like, man, would you mind? And like, I get it, everybody else needs to go home. We need someone to do it. It's good. Then my next year after that,
Hey guys, we have until 3 o'clock. So people, if you want to continue practicing, you can. There, if you need to leave, then there's a sharps container on the floor on the box over there. And just please put the pig's feet back onto the black bag. And then we have a large black garbage bin in the back if you want to clean up and stuff.